Good morning, everybody. This is the electronic visit verification stakeholder meeting. Thank you for joining us. It looks like we only have a few stakeholders in the room and a lot of department staff. There are quite a few folks on the webinar. We have about 70 folks on the webinar. So thanks everybody for joining us either in person or electronically. My name is Lana Eggers. I'll be facilitating the meeting today. If you all typically attend this meeting and were absent last month, I am a new voice. Danielle Walker is on leave for the next few months, so I will be facilitating this meeting until her return. So again, thank you for joining us. All lines have been muted. We were getting a lot of background noise when we were getting the presentation up and going. If you would like to speak and you're on the phone, please hit *6 and that will unmute you. I realized that we did have some issues with unmuting last month. We have been working with our technical assistants to make sure that does not happen this month. But if you are having issues, please let us know in the chat box and we'll do our best to resolve that. So as usual, we will start with our department mission, which is improving healthcare access and outcomes for the people we serve while demonstrating sound stewardship of financial resources. For those in the room, you probably all know, but our restrooms are right outside this door near the elevators. If you are looking for accessible bathrooms, they're on the 4th and 7th floor, and gender neutral are on the 1st floor. So we'll start with some HCPF introductions. Like I said, my name is Lana Eggers. I'm the Waiver Administration and Compliance Supervisor. And we'll go around with HCPF staff in the room, and then we'll see if we have any staff on the phone.
My name is John Lentz. I'm the EVV policy specialist for the state plan side. And I might be a little bit quiet during the meeting because I'm answering the Q&A online.
My name is David Navas. I am the new quality assurance specialist for the EVV program, and I started yesterday, so kind of a long learning curve to go to.
I'm Ryan Fitzgerald. I work in the waiver administration and compliance unit with Atlanta.
Thank you.
And, excuse me. I'm Selena Martinez. I'm with Participant Directed Services, and I'm the FMS Contract Manager.
And then over here.
I'm Jenna Kapp. I'm working with SB 195, the Children and Youth Behavioral Health Enhancements on the project board.
My name is Ruth Webb. I work with Lana in waiver and compliance. I'm an HCBS policy advisor.
Alyssa Kazan, EVV Operations Analyst.
Jody Davison, EVV Project Coordinator.
Sydney Donati-Leach, EVV Data Analyst.
Great, and do we have any HCPF staff on the phone that would like to introduce themselves? As a reminder, all lines have been muted, so please press *6.
Hey, Lana, this is Matt Calusi, Benefits Section Manager.
Hi, Matt. Okay, so the purpose of this meeting is to engage providers, members, and other stakeholders as the department works to implement electronic visit verification for community-based services offered through both state plan and waivers. Specifically, we will review EVV, the legislative mandate, and the scope of implementation. We'll discuss project updates and provide a platform to gather stakeholder feedback. We ask that you mind your e-manners. Identify yourself when speaking. That's especially important today since we do have so many folks on the phone. Share the air, listen for understanding, and please try and help us stay solution and scope focused. For the agenda today, we covered introductions. We'll go over a brief overview of EVV like we always do in case we have any newcomers. We'll go over the live-in caregiver definition. We'll talk about the scope of the EVV program. We'll discuss the claim edit. We'll talk about the plan data call center report out. And we'll go over stakeholder engagement, kind of figuring out what you all would like to see for stakeholder engagement going forward. So excuse us as I did rearrange the agenda a little bit from last time it was sent to you. I've moved the stakeholder engagement discussion to the end of the agenda, but we will get there. All right, so what is EVV? I'm sure most of you guys know this by heart by now, but we'll go over it one more time. Electronic visit verification is a technology solution which verifies information through a mobile application, a telephone, or a web-based portal. EVV is used to ensure that home or community-based services are delivered to people needing those services by documenting the precise time that services start and end. Why are we doing EVV? This is not something that states choose on their own. It's a federal mandate. Section 12006 of the 21st Century Cures Act requires all state Medicaid agencies to implement an EVV solution. So it is a congressional mandate. States who do not implement EVV will incur a reduction in federal funding. And the department intends to implement EVV for all Colorado required services in late summer 2020. Most of you all know that we have been approved for the good faith exemption, so that's why this date has moved to late summer 2020 instead of January 1st. So it will not be happening in about a month. But we'll go over that a little bit later. So what is the core of EVV? EVV must capture 6 points of data. Those include the type of service performed, the individual receiving the service, the date of the service, location of service delivery, the individual providing the service at the attendant level, and the time that the service begins and ends. Which types of services are required in Colorado? In Colorado, we are implementing EVV for select fee-for-service, state plan, and home and community-based waiver services. Services that are exempted from EVV in Colorado include per diem services, services offered through managed care, through the Program for All-Inclusive Care of the Elderly, otherwise known as PACE, or other capitated services. The list of services which require EVV in Colorado is on the slide now. That would include personal care, pediatric personal care, home health, including RN, LPN, CNA, PT, OT, and SLP, private duty nursing, hospice, homemaker, respite provided in the home or in the community, consumer-directed attendant support services, or CDOS, in-home support services, which is known as IHSS, independent living skills training, life skills training, physical therapy, which is provided in the home, occupational therapy provided in the home, speech therapy provided in the home, behavioral therapies provided in the home or the community, pediatric behavioral health, youth day, and select durable medical equipment services. And just a quick piece on durable medical equipment. A few months ago, we released a really long code list for DME. It was all of the codes for DME. Since new federal guidance says that states can have a little bit more authority and a little bit more autonomy when they implement EVV for DME, we have pared down that list substantially. So there aren't a lot of services under DME that do require EVV, however, some do. It's services that require an in-home setup, and there's a few other criteria. And John, do you know, has that been posted online? Yep, okay, so the new DME code list is on our EVV website. Is it on our EVV website?
Oh, sorry, it's in clearance to be
It's in
posted
clearance,
online,
okay.
sorry.
Yep, no
It
worries.
will be posted very soon.
It'll be posted very
Yeah.
soon. Okay, no problem. So we'll get that posted really soon. It'll be under the resources page of our EVV website. So the page now is talking about the service groupings. So within our state EVV solution and provider choice systems, we have pared down our list of services, which was very, very long when you take into account unique procedure and modifier codes. And we have broken it down into the groupings you see now. When an attendant goes out to collect EVV data, they will clock in and clock out by selecting one of these service type groupings instead of a very specific EBD relative personal care code. So we don't want attendants to be scrolling for 10 minutes before they get to the code for the service they're providing. So these are the service groupings that an attendant will choose from. This goes for the state EVV solution. And if a provider chooses to use their own EVV solution, their solution will also have to accommodate these particular service groupings. They are in our technical specifications, so if you are utilizing an alternate EVV solution, you would hand these to your developers and they would understand that this is something they need to work into the system. So we still get a lot of questions around service location. We've had this slide on our presentation for quite some time, but it's still important to go over. The department does not intend to restrict location of service delivery with the implementation of EVV. We recognize that services required under EVV happen in both the home and the community, and it's essential that EVV does not disrupt that. So wherever the attendant is providing the services, whether it be in the client's home or at the grocery store or at grandma's house, the attendant would simply clock in and clock out where services take place, with the exception that if the service takes place in a facility or a professional building, it is exempt from EVV, and you'll see that within our large code list. Are there any questions or comments on the overview of EVV? Alec, yes.
Yeah, it's Alec Hassan, Alpine Home Care. I think I've asked this before, I just don't remember 100% the answer, but when we talk about the service code groupings, personal care and homemaker for IHSS would be under IHSS rather than under personal care and homemaking. Do I remember that correctly?
Yep, that's correct. If a caregiver is billing for the provider associated with the caregiver is billing for IHSS, they would clock in with the IHSS grouping and not the personal care or homemaker grouping. Yes, in the room.
Sean with Love Foundation. Has there been optional agencies or systems that have been identified that the state will work with?
Sure, good question. So there have been a handful of providers which have interfaced with Sandata in Colorado and Sandata in other states. On our website, we have a list of all of those providers. We update that when a new one does connect. The department does not endorse any specific provider, but we do give you the list of providers who have connected with Sandata. And if they have connected with Sandata previously, it does reduce interface timing. Yeah, so that is on our website. I believe it's on the Provider Choice Systems page on our EVV website. And if you have a hard time finding it, let us know through the EVV inbox, and we'd be happy to send you the link. Yes?
Yeah, just a follow-up to her question. It's Alec Hassan here again. Are there any updates? I understand that new providers are now waitlisted because all the slots have been filled. I guess we're waiting for contractual resolution. Any news as to the timeline when new providers will be able to access to start interfacing?
Sure, good question. In the last stakeholder meeting, we let folks know that we have hit our contractual limit for new providers interfacing with Sandata in Colorado. That was due to a lot of new providers coming into the EVV field after we executed our contract quite some time ago. So new EVV systems that are trying to connect with Sandata for the first time in Colorado are put on a wait list until we have our contract amended. That is currently with our federal partners, and we anticipate approval early next year. So if you are working with a provider who is not interfaced with Sandata in Colorado or in any other state, you will begin interfacing likely in early January. If the vendor that you're working with does interface with Sandata in a different state between now and then you would be cleared to begin interfacing in Colorado. Anything else before we move forward? All right, so some quick key terminologies, and I apologize, sometimes I do use these and mix them up a little bit, so maybe tell me if I'm being confusing, if I'm using the wrong term. But real quickly, the state EVV solution is the state EVV system available to providers at no cost. When I talk about the Sandata system, that's the free EVV solution offered by the state. The provider choice system is an EVV system procured, purchased, and used by the provider. Alternate vendor is a vendor who manages the provider choice system. And the data aggregator is where provider choice systems will submit data to the state EVV solution. That's the system responsible for combining all of the data and making sure that it looks right when it's transferred to the state. So Colorado has selected the hybrid model. You also hear that referred to on the federal level as the open model. That means that we have selected a vendor that will provide an EVV solution in Colorado, while we also allow providers to utilize their own EVV system or that of their choosing. Providers choosing an alternate EVV vendor must ensure that their system is configured to Colorado rules and requirements. Provider choice systems must connect to the data aggregator, and self-paced aggregator training must be completed prior to connection. If you do look at the EVV website, there are some detailed steps of what connecting with Sandata looks like. So you'll find some more information there. A brief overview of the EVV solution. I'm going to try and breeze through this quickly since I know many of you have heard this quite a few times. The Colorado Sandata solution offers a mobile application, a telephone option, or a provider web portal. The mobile application, mobile visit verification, is a GPS-enabled mobile application that's downloaded on a smartphone or tablet. We're utilizing a bring your own device method, which works for iPhone and Android. That means that the state will not be providing any technology, any phones or tablets to providers or attendants. It is GPS enabled, so it captures location when the caregiver clocks in and they clock out. However, there is no continual location reporting. The location of service delivery is recorded just at time of clock in and clock out. The state or Sandata will have no record of where the attendant and the member go in between those two times. Direct care workers will log in with a unique Sandata ID or an email address, and it is available in a handful of languages. These are the most commonly spoken languages in Colorado. They include English, Spanish, Somali, Russian, Chinese Mandarin, and Arabic Egyptian. The mobile app does work in rural areas with a few caveats. The MVV app will automatically switch to disconnected mode if it doesn't have any service. Once service is regained, whatever information is input by the caregiver at that time will just upload to the solution, and it will connect and be sent to the provider. So continue to use the app when you don't have service, and it'll upload later. You can also use the telephone visit verification if you are in an area that doesn't have service and you'd like to use telephone, or if you just choose to use this methodology. Each provider agency who uses the state EVV solution will have two provider numbers. They're located on opposite ends of the country, so we're accounting for any type of power outages. Both numbers are accessible 24/7. This is the option if a caregiver or a member choose not to utilize GPS. The client phone is preferred for this type of verification. Location is captured through ANI technology, and the member is identified through the Sandata client ID. That's versus the Medicaid ID, because there is an alpha in the Medicaid ID. We weren't able to type that into a phone, so you have to utilize the Sandata ID. And direct care workers are also identified by a unique Sandata ID. The last piece of technology within the state EVV solution is the provider portal. This is used for visit maintenance and administrative tasks. It does have limited capacity for manual entry of data. However, providers who choose to enter manual data will be subject to thresholds. And we have discussed that quite a bit, but the state has not developed those thresholds yet, and we will keep you informed when we do. It is CMS guidance that we do not allow for all EVV data to be entered in the provider portal. It is kind of like the last resort. The provider portal is used to view and verify visits and address any exceptions or errors. So if an attendant forgets to clock out, clocks in for the wrong service grouping, or otherwise the visit needs to be adjusted, this would be the platform for which a provider could make those edits. Okay, do we have any questions on the old information that we just presented? As a reminder, folks on the phone, you are muted. Please press *6 if you would like to speak. Okay, you guys are all up. You can always count on one.
Sorry. I need to be a pain, but
No, you're
just to review. So if we're talking about this whole verification, landline versus mobile app. So if a caregiver delivers a service in the community, the only option to clock in and clock out, I assume, is through the mobile app. Is that correct?
Not necessarily, no. If a caregiver and the client are in the community, they can still use the telephone option. And they would select, we'll have to release some guidance on this because every time I say it a little bit differently, and I'm probably confusing folks, but there's an option on the telephone system that indicates that you're not in the location that we would assume that you would be in. So the caregiver would say, I'm not in that location, I'm not in the assumed location, and then they would let the provider know where they are. So instead of clocking in and clocking out with GPS, it would be the responsibility of the caregiver to make sure that the provider agency was aware of where services took place if they were using the telephone option.
Okay.
I know.
So truthfully, to me, clock and clock out on the mobile app as you push the buttons. You're saying the caregiver is using his cell phone to call and use telephony, or how does it work? Or do I go to a payphone?
You can use any phone. We do prefer that TVV is used from the client's phone, so we can assume that it's at the address associated with the client's home phone number. If it is a different phone number other than the client's home phone and they're in the location of the client's home phone, then we would expect that the attendant would correct and let the provider know exactly where services did take place.
Okay, but again, the clock in and clock out in the community, assuming the mobile app isn't used, is telephony. So the caregiver would call from his cell phone, would call the telephony number and go through certain steps. And you're saying in there's a step you can say, I'm not at the assumed location?
Exactly, and I can't remember what exactly the prompt is. Do you know what it is, John?
I do. So it'll ask if you have any tasks. The only task is alternate location. And so as you're calling in, then you would notate that you have a task and it's option 1 instead of option 0. And then that puts in a notation that it needs an alternate location. So that alternate location would be entered by the administrator afterwards. And so the caregiver at the time can just notate where the care is actually being delivered, and then everything comes across clean.
You're saying
It generates an exception, sorry. That requires the need for the administrator to want it.
Correct, it does generate an exception.
and this is LaShawn again, you're saying it has to be done from the client phone, not from the provider phone, or it can be done from the provider phone?
EVV can be used from any phone.
Okay.
I definitely understand that I probably explained that inadequately. Thank you, John, for jumping in. Let's plan, Jody, can you help us with an action item to get out some instructions for how to do alternate location with TVV? Thank you. We'll work to get you guys some better instructions on that, but it is a functionality that is available.
But if you're meeting a client at their home and then traveling, escorting, accommodating with them, you can log in through the mobile app and then still leave the location with the client for community integration or whatever that may look like. and then log back off once you get back to the client's home?
Yep, so an attendant should clock in whenever they begin service delivery. So whenever the provider agency would start billing for services, that's when the attendant would clock in, regardless of where they are.
Okay.
And then when service is done, they would clock out again, regardless of where they are.
Thank you.
Sorry, final promise on this. Just to clarify, so if I'm in the community and I use the mobile app, there's no exception generated, right? But if I am in the community and I decide to clock it in via calling the phone number, then there's an exception. As long as I put in alternate location, or what happens if I say, no, I'm just confused, I'm not here?
Can you,
So you said there's a task list and then a prompt where I can do 1 or 0, whether I'm at home or alternate location. So what if the caregiver makes a mistake and says, I am at home, whatever the prompt is, 0 or 1. Does that still generate an exception then, or?
It will only generate an exception when the alternate location functionality is indicated on TVV. So if the caregiver makes a mistake and doesn't indicate alternate location where they should have, then it will not flag an exception for you.
Even if they didn't call in from the expected phone number?
I believe that is correct, but that said, I would like to double check with our folks who are more familiar with this functionality.
That'd be important because that is, from the provider's end, potentially a lot of administrative work that needs to be done. Or let me put it positively, caregivers need to be trained to use it correctly, because otherwise you end up correcting every single clock in, which obviously would be a nightmare.
Yep, absolutely. Do we have any other questions or comments before we move on to the new information in the presentation, or at least the project updates?
This is Andrew with Pasco. Just a follow-up question about the telephony.
Sure, Andrew.
Is the thought that each client record would still have a phone number loaded that would be the expected phone number that the telephony calls would be coming from?
Yes. So the primary phone number in the client's record under the state EVV solution is the expected number for the telephone visit verification. I'm also making eyes at my project manager to get a head nod, Veronica.
Yes, that's my understanding as well.
Okay. And then if you call from that number, would there still be that prompt to ask whether or not it's an alternate location?
I believe that prompt is there regardless of which number you call from, so it will always be an option. In case, for example, if a primary phone number is a cell phone number, the assumed address would be the client's home, but if you're out in the community, it would still allow for you to indicate that you are not in the assumed location.
Sure. And the task list would be prompted regardless of which option they picked, right?
I believe that when you call the number, you will be asked if you're in an alternate location, and you can hit yes or no. If you hit yes, then that's when the task of alternate location will be generating the exception.
Okay. Would you still receive the other tasks related to that visit?
There are no other tasks in the state EVV solution.
Yeah, you'll get asked if you want a task to input, and then the only task is alternate location. So ask for a task. Yes, included in alternate location.
Yeah, so the only task functionality in the state EVV solution is that. And that was Alyssa from the unit put me out here.
And then the agency file would need to provide an address that gets sent to the aggregator, or a GPS cord or something.
Can you say that one more time, please?
If they do say it's an alternate location, what exactly does the agency need to provide? Is it an address or a GPS coordinate?
So if that does happen, there is an alternate location field that the provider would enter. That field can take a few different formats of location. It can take a street address, a GPS address, or a landmark address, like a Disneyland or a city park.
Perfect. Thank you.
Sure. And like I said, I think that the state fumbled through that a little bit, so thanks for bearing with us. We will get out some written documentation so that is a little bit more clear. One more in the room.
Is there any way in the system to not call it task list? Because, you know, task list typically in these types of system mean the real tasks, dusting, cleaning. So having it under the label task list and then really ask for an alternate location is a little bit confusing, especially between provider choice and EVV systems.
Yes, definitely understand that utilizing the term task is a little bit confusing for this. We did have to utilize that term because the state purchased a commercial off-the-shelf product from our vendor. Because of that, we didn't have a lot of flexibility in how we manipulated the system. We asked them to create this technology for Colorado, recognizing that, providers and stakeholders in Colorado have asked for a TVV location collection methodology. That was a lot. So we really didn't have another option than to utilize that current functionality and that title.
One more. What does that mean for provider choice systems? So does I don't remember the aggregator specs, but is there an alternate location field that needs to come across? Or does this only apply to the state EVV system?
It should also be a task part in alternate locations.
Melissa, is that part of these technical specifications that there is that alternate location?
Yep, the ones that are on the website are on there.
Okay, so that was already in there. So
Yeah, I did.
Seeing that, but I don't remember a lot of things. So that's
It's a long, complex document, and that hasn't changed since we released it in June.
So this needs to be replicated in the provider choice systems along the same lines, which is fine. I just wasn't necessarily aware of that. Okay, one more thing to add to the list. Okay, thank you.
Great. Okay. We good to move on? I see a head nod. Thank you. Okay, we have been over this before, but I realize that the shift in timeline is not as straightforward as we'd like it to be, so I'd like to discuss again quickly. Colorado applied and was approved for a good faith effort exemption from the EVV mandate. That is an option within the 21st Century Cures Act. A state, if they would like to ask for an additional year to implement and require EVV, may do so. We made that request in September 18th. We were approved, we made the request early September. We were approved on September 18th. What that did was permit us to move the mandate from 1/1/20 until sometime in the calendar year of 2020. So you've been hearing from us for probably a couple years now that the mandate is coming. We psyched you a little bit, and we decided to push it back to give Colorado and stakeholders a little bit of extra time so we can exempt live-in caregivers. Pretty late in the game, after our systems were already developed in the state, CMS released guidance that live-in caregivers do not have to complete EVV per the congressional mandate. Colorado has decided to exempt live-in caregivers from our Colorado mandate, although individual provider agencies may still choose to collect that data. But we have decided to push the mandate date out. We anticipate we will mandate EVV in late summer of 2020 for the purposes of live-in caregiver solutioning. We don't currently have a way to identify who is a live-in caregiver and how we would exempt them from the EVV mandate. This next slide is a visual representation of kind of what our process is right now. So on October 1st, our state EVV solution and the data aggregator became available for providers to utilize. We are in our early adoption or voluntary soft launch time frame. What that means is providers and caregivers can get in and use EVV. collect EVV data, learn to use the system. We highly encourage providers and caregivers to get in soon and early. This will help mitigate any issues going forward. It'll make sure that everybody knows how to use the system ahead of the mandate. However, it's completely voluntary. You don't have to. Right now, we are exploring live-in caregiver solutioning to figure out how to exempt that particular population of caregivers. We are working through that right now. I don't have a lot of updates on that other than we'll be providing you with a definition of what a live-in caregiver is on the next slide or two. And then we do anticipate the Colorado mandate and the CCR rule going into effect in summer of 2020. And then on January 1st, 2021, we anticipate having a prepayment claims review. So that means that if you are not utilizing EVV for required services, there will potentially be impact to claims processing. We'll go over this a little bit more. John, in a few slides, is going to talk about what our claim edit looks like and how you know if you're utilizing EVV correctly. And then we'll have Sydney talk about what data we're seeing now within the soft launch, all these early adopters that we so appreciate. So one of the first steps in solutioning for our live-in caregiver exemption is defining what is a live-in caregiver. Within the federal guidance, they have not told us what a live-in caregiver is. There are a handful of definitions, both that are used at the state level and that are used at the federal level. So we worked with we had an internal HCPF work group, and then we also worked with our consumer-directed and family caregiver subcommittee to work through a definition that might be acceptable and that will work for the purposes of exempting living caregivers in Colorado. It's on your screen now. Bear with me. I'll read it out loud. So the definition we intend to use in Colorado is a live-in caregiver is a caregiver who permanently or for an extended period of time resides in the same residence as the Medicaid member receiving services. Live-in caregiver status is determined by meeting requirements established by either the U.S. Department of Labor or the Internal Revenue Service. Verification of live-in caregiver status must be validated by the provider through an official department form. The department permits live-in caregiver establishment beyond the above definition in limited circumstances at the department's discretion. Examples may include joint custody arrangements, children living in foster care, and members transitioning out of a residential service. And bear with me, I got a notification on my screen that we might have lost the connection. Can folks on the phone still see the presentation?
Gonna raise hand. Yep, yes.
Yes, okay. Thank you for the feedback. Kelly, it looks like we might have lost our closed captioning. And then just a note on this definition, live-in caregiver status is established by the member-caregiver relationship. If a caregiver provides services to more than one member, the establishment of live-in caregiver status only pertains to the relationships where documentation has been provided and approved. For example, if we have a parent providing care to their child, which they live with, that parent might also supplement their income by providing services to another Medicaid member. That live-in caregiver status must be established at each relationship level. So because that caregiver is a live-in caregiver for one Medicaid member, we would not assume that they're a live-in caregiver for any other Medicaid member for which they provide service. So that was a lot. We have made a few edits to this definition since we met with the Consumer-Directed and Family Caregiver Subcommittee, basically on their recommendation. It sounds like the development of an official department form was what folks were looking for, so we will be developing a form that establishes the status. We don't have it yet, but we will get it done. And then I would kind of open it up for discussion if anybody has any comments or thoughts on maybe any unintended consequences that this definition might create. Yes, Alec.
Alec Asper, Alpine Home Care. The form, that's something that we collect and need to keep on file, or is that something that we have to collect and then send to EVV? Where does this form go?
Great question. We are still working out what exactly we will do with that form. What we do know is that the provider agency will be responsible for collecting it and having it in their files. What we don't know is when the department will need it and when we'll look for it. If we'll expect that you send us all the forms, if we'll check for it during a survey, we haven't gotten to that part of the process yet.
Just as a follow-up, that somewhere in your system or in DXC or wherever, I assume there's need to be a flag that says this client is a live-in, so don't expect an EVV file, in order to pay this claim. So that would say to me that somebody needs to input this. Have you guys decided if that's you guys, and by you I mean HICPAF, DXC, whoever, or the provider? Because if it's somebody other than the provider, then I would argue you probably need the form to be sent to you, and anytime there's a change to that form made as well. If it's the provider, then it can all stay with the provider, I would assume.
Yep, those are all really good comments. Part of the reason that we have requested that delay is we don't know the answer to those questions yet. Because our state EVV solution and our claims processing through our interchange were already kind of set in stone when this guidance came out, we have to revamp our system a little bit to figure out how we're going to incorporate. But we don't have an answer to that yet, but definitely understand we'll need that information to make sure claims are paid correctly. Do you have any other comments or questions on this proposed live-in caregiver definition? I heard some. Andrew unmuted, so now I know that the phone's working, so thank you, Andrew. Okay.
Sure.
We'll keep you guys updated.
This is Andrew with Pasco. Just one quick question.
Sure.
Have you guys considered adding familial relationship as a possible exception? So if it's, maybe a sister and uncle that lives across the street or nearby and comes in to provide personal care service, for example, would that suffice, or is it really just primary residence and custody that would be considered?
We do have to limit it to living together. The CMS guidance indicated the exemption would only be for live-in caregivers. We did follow up, and they let us know that it is folks living under the same roof. How the state defines what living under the same roof is a little bit up for negotiation, which is why we've leveraged existing definitions for that. But it is only for live-in caregivers.
Sure. Thank you.
Okay. Yes, ma'am.
Marina with Super Healthcare. Regarding the conditions that you were talking about that are exceptions, what exceptions do you have in mind, or have you considered to this definition, or nothing has been done yet?
Sure. So the possible exceptions to those already established definitions, the ideas that we thought of were the ones listed below. So we know that the U.S. Department of Labor and the IRS definitions are a little bit rigid. It doesn't always accommodate for folks that may live in different homes during different times of the month. We had some stakeholders let us know that joint custody arrangements can be common and wouldn't fall within those definitions, so we put that on there. Joint custody arrangements, children in foster care, and members transitioning. Those are the only exceptions that the department could think of. However, our definition does say may include, so if you have any other ideas on what might not be covered with those pre-established federal definitions, let us know. Our intention would not be to restrict anybody from getting the exemption when it would be appropriate. So please let us know, and we'd be happy to take that feedback. Okay. I'll move on unless anybody else has any questions or comments on this. I do see a Q&A saying that connection was lost. Our folks are looking into that to make sure everybody can see.
But our in-room audio expert is saying that he's logged in and can hear. So
Okay.
if anybody else is having trouble with
Webinar.
connectivity, please let us know.
Yeah. Can't see the webinar, please let us know. Thank you. Okay, so EVV project scope. I'm going to pass this off to my colleague here, Sydney. She is our data analyst. I'll let her introduce herself, and she's going to talk about what EVV is currently doing in Colorado, since we do have some early adopters.
Sure. So again, I'm Sydney Donati-Leach. I'm the EVV data analyst. The department receives all data that is submitted through the Sandata aggregator. So anybody who is currently using the system, we can see them. So in this table that you can see, just had a quick summary of the utilization so far. You see service type in the left column. As you can see, not all service groupings are here. This is because not all service groupings have a visit associated with them yet, or have not had a visit submitted yet. So this is not a complete list, just the ones that we've gotten data for. The column just next to that is our client count for each service grouping. You can see at the bottom, we have about 300 clients who have received EVV services. These are distinct clients. So within each grouping, you could have somebody receiving personal care and pediatric behavioral therapy, and that client could be in both groups. Then the column to the right of that is our visit count. So that's how many visits we've gotten since go live. And we've had roughly 1,600 visits since the program started. And then finally, providers, we have about 37 providers. And again, providers could be in different groupings. So keep that in mind. This isn't parsing out each provider. They could provide services for different groupings there. Then the next slide, we have verified and unverified visits. So I kind of wanted to break down that 1650 number from the previous slide and show you what that looks like on our side. So just to briefly go over verified versus unverified, the state considers verified visits to be complete, where all data points are collected, and this would make it a cures compliant visit. That means that the visit will be able to match to a claim line. Keep in mind, this does not mean it will match to a claim line. It's just possible for it to match. And then the inverse of that is an unverified visit. This is incomplete, meaning one or more data points are missing from that visit. This is not cures compliant, so it cannot match to a claim line. This is a situation where an exception is thrown and the provider agency must go in and fix one of those missing data points in order for the visit to be verified, to be completed, and for it to be cures compliant, and then finally possible to match to a claim line. So you can see we have verified visits, about 263 verified visits out of the total the total of 1,650. And of course, just subtracting then unverified visits, we have 1,387 in unverified visits. So our percentage for verified visits is fairly low right now. It's about 19% of visits coming through are verified. So just a reminder for all providers and all provider agencies to make sure you're going through and correcting any missing data points, to acknowledge any exceptions, and then you will be able to have claims that can match to those visits. Sorry, claim lines, because it is matched by claim line, not the claim overall. So that's kind of an overview of the system and the data we've received. And now John is going to go into some details on what it means if you get an error code on your claim line.
So this is on your remittance advice that all providers get from Colorado Medicaid. The first part is from the provider newsletter that was sent out by DXE to all providers, talking about the explanation of benefits, the 3054, which is just the EVV record required and not found. What this actually looks like on a real RA is on the next slide. And this is a real RA that everything has been blanked out, but it was run on 11/15, so this is the very latest one. And this is showing that on each line, you can see that it's not just saying general advice, that, you know, there's general advice, just pay attention to EVV. It is actually by procedure code that comes across. So you'll actually be able to see in pretty great detail if your individual claim does not have an EVV. So this is already set up, this is already totally live. If you're curious if the EVVs that you're submitting, and you know that you're billing in a certain way, and you're putting the EVV through in a certain way, and you're pretty sure that it works, this is where you can check it out and see exactly that service from to service to date with that code has an appropriate EVV. Does anybody have any questions on this?
All of it? Just this part?
I was thinking just this part, but what do you got for us, Alex?
I have some questions on data stuff, but okay, I'll start with a question on this. It's Alec Cassidy, Alpine Home Care. Did I understand correctly that so late summer 2020, all providers are required at the latest to start using EVV? It's no longer an option, it's a requirement. But then the link to billing does not occur until 1/1/2020. 2021, when the CMS mandate officially goes live?
That is correct. That is correct. So we
That's
have
kind of new information
this.
to me. But
This claim edit is in place because we developed it before we went forward with the delay. So this is just for your information, but you all should really be paying attention to this once EVV is mandated. And sorry, John, I'll
right, but there's
field the rest of the question.
I mean, it's very important and it's good to have, and it will continue to display even after late summer. But the real hammer comes down 2021, when having this comment there will mean you won't get paid. Is that correct?
Yes,
Right.
yes,
Yeah.
that is correct. So this 3054 lets providers know that this claim, right now it's an FYI, this claim needs EVV, voluntary EVV. Once EVV is mandated, this claim line is required to collect EVV. January 1st, 2021, this claim is subject to denial if it doesn't have EVV. So this is letting you all know if your EVV process is working or if it's not working. So this is how you'll know if you are compliant.
Right, and there's a certain escalation level in there, which I think makes sense. So just paraphrasing, if CDPHE comes in after late summer and sees, hey, you guys are not using EVV, but you're supposed to because the state of Colorado mandated it, you know, you're gonna get dinged in your survey. But then in addition to that, if you're in 1/1/21, you actually won't get paid. Is that the right way of looking at it?
We don't yet know what the relationship with surveys will be. So if we take the survey piece out of your explanation, that would be the explanation. Now it's for your information. Once the mandate is in effect, you will know if you are compliant by looking at your RA, and then your claims are subject to denial on January 1st, 2021, unless the department states otherwise.
Isn't that what I said? Okay.
Yeah, the one thing you mentioned was about the surveys and how CDPH&E will be looking for EVV compliance. We don't know if CDPH&E will have an involvement there or not yet. That was the one piece I wanted to correct.
It's a mandate and you have to use it. Like their mandate is to make sure you're doing everything correct. Okay, never mind.
Yeah.
Should probably issue guidance on this. Just to clear it up, we should, because this is confusing enough that we're going back and forth. We'll look at trying to make sure that we have it really clearly defined and spelled out going forward.
Hi, this is LaShawn again with the Love Foundation, and excuse my ignorance on this, and this has probably been covered through all of the stakeholder meetings. However, I don't know the information from an ask. Will the system, with the clocking in, clocking out, if it is done properly, will it automatically bill for you, or are we still required to go in and bill for those services?
Can I take this one?
Of course, John.
This is John Lentz from the department. Thank you so much for asking this. This is actually a huge point of confusion for a lot of people. EVV is a completely separate and unique program that is verifying that the visit is done. It does not automatically bill the department, and this is actually a really good thing for providers because it's all of your normal billing product or processes that you're doing already. Keep doing those, and you're going to have a record of the visits. And a lot of providers administratively really love this because it really shows what the care is being delivered and how everything's going. And it shows that real-time record that's being uploaded at the time of service, all the rest of that. That's very useful, but the billing process, if that's directly tied in, it gets really convoluted and really kind of confusing. And then if you change the EVV and everything, then that changes your billing. And then especially if people have third-party billers, or if you hire a new biller and then they have to know everything about the EVV system, all the rest of this. So it's its own standalone program that provides the verification for it. Please just keep all of your billing as normal.
Thank you.
Excellent question.
Has the department looked at the increase of reimbursement rates? Because this is a huge administrative kind of work that you're putting on us, the providers, to do, in addition to everything else we're doing right now?
Sure. So the question was about, has the department looked at increasing reimbursement rates for EVV? The department is continually looking at our reimbursement rates, comparing them to the national averages, comparing them to a variety of state specific components. So we are always looking at that. At this time, we don't have any rate increases that will follow along with EVV. However, we will go through those processes and we'll continue to look at that. Yeah. And just to clarify, so the federal mandate does not come with any increased revenue for the state. So we don't have any increased revenue for this, so any rate increases that would be a result of EVV would have to be legislatively appropriated. Okay, do we have any other questions or comments? We have about 10 slides left and about half an hour left, just as a time check.
This is Andrew with Pasco with a quick question. The comparison is looking at whatever EVV data is in the aggregator at the time that the claim was submitted. Is that correct?
Yes.
Yes.
Okay. So if you entered a manual EVV entry and then resubmitted the claim, would it potentially be processed the second time?
Yes. So this is John with the department. Please keep in mind that we're working on enterprise level systems, and so the things take time to upload in batches. So they upload at night. So if you, on day one, you update the EVV, on day at least 2, but it needs that time to come across as a batch. Then it comes into the aggregator for some systems, or if it goes right into the aggregator, then it does still need the upload into DXC or the MMIS, and then from there, that's where it's doing the matching. And so if there's a really quick turnaround, if you as an administrator are looking to update immediately and then bill immediately, a lot of times that is going to not match directly against the updated EVV. Is that what you're asking, Andrew?
It is, yep. So in that scenario, maybe just wait a day or 2 and then resubmit.
Yeah.
Perfect. Thank you.
Thank you. That makes sense to everybody in the room.
How long is the delay? Sorry, is it updated? I missed it.
Within the system, it updates at night, so or technically 5 a.m. 4:40. 3
early in the morning.
Yeah, super early. Hopefully you're asleep by then. But it batches up at night. And so it comes into the aggregator, which you can view and you can see all of the entries, all of the EVV entries that are in, right? And it's totally accessible by your administration, but then that needs another day to come over to the state.
Okay.
That should be clearly communicated because that's very different from how it is now. I mean, one of the best things going from whatever we had before to DXC was you put the claim in and you see right away denied or paid, like instantly. So if that goes away, that definitely should be communicated so people are aware of that.
So, and this is a great point. So all of the billing systems are staying the same. EVV is a separate and unique program. The EVV program does take the data upload, but then you'll be able to bill and see if it denies or pays right away. Nothing changes with billing. It's just the EVV upload.
Well, what changes is, if I understood this correctly, you know, I've updated the EVV in the system, but if I go in right away like I'm used to and try to bill that claim, it will still deny because the EVV hasn't reached the billing system yet. So what I'm talking about is it needs to be clearly communicated that if you're making a change to EVV, you know, please allow a day or so for the information to reach DXC, and then you can rebill and you will know whether you got paid or not. Otherwise, you will just not get paid because whatever you correct hasn't made it through yet.
We'll put that on the list of things that we owe stakeholders to make sure that it's clear.
Thank you for the comments. This is great.
All right, is there any questions for John or Sydney before we move on to the call center report?
Sorry, one quick one. Sydney, is it correct to view this as, so verified visits are clear. The unverified are really the visit attempts, right? It wouldn't show up if somebody just went, performed their services, but neither clocked in nor clocked out.
Any unverified visit is missing one or more points of data. And that's really the good way to describe it. So maybe they are missing both the call in and call out, but there's a service, there's a client, and there's a provider selected. So it's really hard to say what kind of data point is missing. It's that one or more.
No, I understand. My question is specifically in your language if all data points are missing. So somebody went in, provided service, but didn't clock in or clock out at all. So a provider who says, okay, I've started using the state system, but I had a caregiver that, you know, didn't clock in, clock out at all, didn't use the app at all during that visit. Would that be in your statistic as unverified visit or not show up at all?
It would not show up at all.
Thank you.
Yes.
Have all clients received, this is LaShawn, Love Foundation, have all clients already that's in the Medicaid system received these unique numbers, and do they have the devices at their home, or will they have the devices at their home for when we start providing services?
For the Colorado State EVV solution, we're implementing a bring your own device method, which means that the state won't be providing any technology. So it would be the caregiver utilizing their own mobile app, It would be the provider maybe giving technology to their caregivers using the client's home phone. We won't be providing any technology. When a provider agency chooses to utilize the state EVV solution, you'll go in and you'll start populating your client information. At that point, that's when a unique Sandata identifier will be given. If you haven't chosen to use the state EVV solution or provider choice system, that identifier doesn't currently exist because an alternate vendor won't necessarily use the same type of identifier. So the first point of decision for any agency is if you're using the state EVV solution, then that sends you down one path and how members are identified, or your own EVV system, and that will send you down another path on how members and caregivers are identified, however that system is set up. Okay, so we'll move on to the call center report. This is just an update on what is happening with our Sandata call center. As a refresher, here's their information. I guess I have email up there twice, so ignore one of those. So these numbers were provided by our folks who help manage of what's happening. And I apologize, these numbers are small. We tried to make them larger and they're a little hard to read. So if you can't see them, feel free to grab the PowerPoint off of our website, and then you'll be able to zoom in a little bit better. But this first slide is on calls presented. This just is an overall kind of layout of how many calls the call center, the Sandata specific call center, is receiving. The presented calls are in dark green, and then the answered calls are in that light green, and abandoned calls are in gray. So what that means is on the first date there, September 7th, we had maybe 10 calls presented and 10 calls answered. If we look over to the middle there, which looks like it is October, I can't even read it, 24th, 12th.
12.
Thank you. We see that we had a handful of calls presented. What number do we see here? About 670 calls presented and a very similar call answered. We do have a little bit of abandon rate there that you'll see at the top. Those are folks that called the number and hung up. But it is good that we have a similar light green and a similar dark green. That means that people who call, their calls are being answered. The next slide is presented calls that are answered in 60 seconds. We have a really high rate here, which means that we answer the majority of calls in 60 seconds. The lowest we got to was right when we opened up the call center. So on September 7th, we had about a 91.5% of calls were answered in 60 seconds. We've been consistently hovering between 93 and about 97% of calls answered within 60 seconds. What that looks like is we have a sufficient number of call representatives there to answer your calls. One thing that the department was acutely aware of going into the Sandata call center is that we did have some issues with our DXE call center when we went live with Commit. So we've tried our best to make sure that this call center is available and responsive to meet everybody's needs. Our current data shows that it is. If you are having a different experience, please let us know. This next slide is percent of calls captured. This is the amount of calls that were answered from all calls presented. So we have a pretty high rate here. You could look at this in tandem with the first slide. We are usually over 90% of calls that were presented were answered. Situations where they might not have been answered could be somebody hung up, maybe they called after hours, something like that. But this is a really high percent of calls who have answered. We're typically above 95%, and in many days we are at 100% of calls answered. And then this last side here is average answer and talk. So the dark green, so those big bars bars are the average time of call in seconds. And that light green, which is a very small bar at the bottom, is time to answer the call in seconds. The information below translates that into minutes, so it's a little bit easier to read. But long story short, we are answering calls quickly, and it's not taking very long to answer providers and stakeholders' questions. Does anybody have any questions on our call center report out?
This is just based on the what? I think we had how many providers in the system?
37.
37. So it doesn't account for the many more providers who are not registered with the system yet.
This accounts for anybody who's called the call center. So some of these calls are providers that just want to learn a little bit more about how to connect with the state EVV solution. Maybe they're using their own system. So this wouldn't just be providers who are currently in the system and using it. It'd be anybody who decides to call the Sandata 1-800 number. So it is a little bit above that. That said, we will see the volume of calls go up substantially, I'm sure, as more providers are getting in the system. We're confident we have the call center representation necessary to accommodate that volume of calls. That said, we encourage you to get in and early, be an early adopter, learn to use the EVV system, get in, talk to our Sandata folks if you have any questions. We're here and we're ready for you. But yes, this is primarily early adopters, but not all these folks have necessarily connected.
And there's also an email option, so you can email him. So this doesn't include all of the emails, which may seem like a little low. So that's another option too.
Okay, thank you.
Okay, any other questions on the call center? Okay, so we're going to briefly go over the EVV roadmap again. You guys are familiar with this slide, but just to let you know how far we've come. We kicked off this project officially in 2018. We began these stakeholder meetings in fall of 2017. So we've been on this path for quite a while. We are in the soft launch phase. Providers can begin to use the systems if they would like. So we'll just keep that up as a reminder of how far we've come. And then just a few quick points on the soft launch. As a quick reminder, the department is allowing providers to get in and use the system voluntarily at this point. They could begin using the system, either the provider choice system or the state EVV solution, on October 1st of this year. Providers can begin to collect data, transmit it to the department. Sydney will receive it and she will process it and we'll kind of know what's happening. That data is very important for us to collect. It helps us understand if the system is working or not. It helps us work towards live-in caregiver solutioning. It helps us understand what sort of potential claims impact there might be if providers aren't understanding how to use EVV. So that data is being used and it's really valuable to us. The soft launch is an opportunity to familiarize providers with the system prior to claims integration. That's that 1/1/21 date that we were discussing earlier. Claims will continue to pay during this time, and you'll see it in your remittance. That's that slide that John presented on earlier. You will know if you're using EVV correctly. It's also an opportunity for caregivers to practice the collection of EVV, so we know that all 6 points of necessary data are collected, and that members become accustomed to EVV. They become familiar with their caregiver clocking in and clocking out at time of service. And it'll help the department identify and develop supplemental training materials. Just in this stakeholder meeting today, I think we have 3 or 4 items that we need to create for you all. You all in the system letting us know what's working or what's confusing is really helpful to us so we can get the right information out to you. So we encourage you to get in the system when you can. We really value your participation. So with that, the last point on the agenda is to discuss stakeholder engagement. We have historically, over the past few years, had at the most 5 monthly stakeholder meetings about EVV. We really love talking about EVV at the state, and it sounds like you guys enjoy hearing about it. So we had, our subcommittees are the Consumer Direction and Family Caregiver Subcommittee, the Training and Communication Subcommittee, the Systems Subcommittee, and the Privacy Subcommittee. We disbanded the privacy subcommittee earlier this year. We worked with that subcommittee to understand if we had any outstanding topics. We dissolved that quite some time ago. And then just this last month, we sunsetted 2 more stakeholder subcommittees. The training and communication subcommittee and the systems subcommittee were both sunsetted this month. The reason for that is our training is live, it's developed, and a lot of providers have gone through the training. All of our in-person and webinar trainings have concluded for this year. The majority of the trainings that are left are self-paced trainings. We will have a few more webinars at the end of the year, but it really felt like we had concluded a lot of the work that was happening in that subcommittee. Same with the system subcommittee. Our data aggregator and our state EVV solution are live, they're running. At this point, the changes that we would make would be because there is a defect, because you guys help us find that during the soft launch period. So we have sunsetted those. The remaining subcommittee is the Consumer Direction and Family Caregiver Subcommittee. We have that meeting next week. We will talk with that group about the purpose of that meeting and if it's the right choice to sunset that or not. So to be determined on that. So I guess my question for you all in this remaining 10 minutes is, how would you all like to use this meeting? Like I said, we've been having this meeting for over 2 years now. We give you a lot of project updates and try to give you information which we think you might find useful. But if there is a different purpose for this meeting, we want to hear from you. This is your all meetings. This is a space that the department has created to learn from you and to give you information which is helpful. So I'm opening it up to folks on the phone. I think we have about 100 folks on the phone and the folks in the room. How would you like to use this time going forward? I'll look to my left because I know that Alec is going to have a comment.
Phone will jump in.
We'll pause for a second. We'll give some opportunity for folks to unmute themselves. *6 if you're muted, and then also remember to mute your own line if you've muted your telephone.
Use me as a last resort.
And if you have any comments, you're also welcome to put them in the chat box. My colleague here, John, is monitoring that and responding to those, so we would be happy to take any comments there too. All right, Alec, floor is yours.
So, I don't know how others feel about this, but for me, this meeting is of critical importance, and it's the one place where you can exchange views and get updates, important updates on EVV. And, I like the format. Perhaps some of the parts that are, a little old and repetitive, I know you need to repeat them because there's always new folks joining, but, maybe if one could shorten that period even further. But other than that, I think the format is good and the information is good, and I think we need to keep going in light of the still many, unresolved issues that we face before EVV is hopefully successfully introduced here. I think we've come a long way and a lot has been accomplished, but, I think it's still a very good use of all of our time to continue with these meetings going forward. That's my opinion.
Great, thank you. And there's a couple in the chat box that I'll just go ahead and read out loud so the group can hear. We have a comment that it would be great to hear from folks who are doing the early rollout and tell us how it's going. That's a great option. If there are providers on this call who are currently using EVV, we'd love to hear from you. Reach out, let us know if you would be open to talking to the group. Our email address, as it always is evv@state.co.us. We would welcome putting you on the agenda to tell us if it's working, what's not working, and just kind of a overall information session. But we need providers to volunteer for that, so please do. We have another comment that it would be beneficial to hear about stucks and challenges providers are experiencing with EVV. It would be great to not have to recreate the wheel if we experience something similar. So a very similar comment that folks want to hear from providers who are using the soft launch. I'll use this as an opportunity to encourage more providers to get in the soft launch. So we have some more folks who could join us in this discussion. Okay, anything else? Yes.
Any updates on travel time? And I absolutely agree with Alec about this as being very beneficial regarding all the updates and just talking to everyone.
Updates on travel time.
Yeah.
Yep, that's a good one. The update at this moment is we're still working on it, and because of the delay, it's just process as usual with travel time until you hear differently. But we are still working internally on that. We will keep you all informed. Thank you. Yes, making sure there's no comments on the
That's fine.
webinar.
That's fine. Just because my colleague over there started, in terms of the deliverables that we still need to see. Just going down my mental list, there was the caregiver communication that I think was supposed to come out shortly. We talked already about travel time. And I guess live-ins we also touched upon, and that connected to the problem of thresholds and how it will all work when this is all put together. But the other thing I'm not sure we mentioned or talked about, at least recently, is what was the procedure or what was the intention for when we get a new client and we're supposed to start services, but that client isn't in the system yet. Did we ever figure out how that would be dealt with?
Isn't in your EVV system or isn't in the state interchange yet?
Well, let's talk state system. This is the client, we get a call from a case manager saying, can you please start services? But we don't have a PAR yet, and we don't really, and let's say it's not in the EVV system either. Can we start services and then go in and do manual entries for the EVV because the caregiver wasn't able to plug in yet? And then does that have to be counted then against thresholds? What is kind of the solution there?
That's a good question. We'll put that on our list of topics to get formal guidance out on. Our intent is to not change enrollment practices for individual providers. So if an individual provider will currently take on the risk of providing services to a client that doesn't have an active PAR yet, we appreciate that service and we don't want to change that with EVV. My tentative answer would be that you would just manual enter EVV for that short period of time. That said, I want to make sure that we get out some formal guidance and I'm not misspeaking on that. So thank you.
When we spoke about this probably a year ago, there was one thought, or maybe it was in another state, where the provider had the capability to input that client, I don't know if it was temporary, into the system.
I think that if the client doesn't have a state ID yet, you can enter in a buffer number, like all zeros or something like that. We do have an answer from our vendor. Does any staff in the room remember what you would enter if a state ID doesn't exist yet?
It's an unknown visit.
Unknown client. Unknown client.
Thank you.
So you can create an unknown client visit.
And then that will trigger an exception that can then be corrected later.
And then you, at some point, enter the state ID. And this would also work, because in most cases we have the state ID, right? The PAR, exists, maybe it already exists in the bridge. It just, takes some time to make it over to DXC.
Right.
So if you have the state ID, you can do the same thing, I assume, with a state ID. Or you have to select, probably more detail than we need.
Yeah, we should put this on our radar to make sure we get out some information on this. I don't want to speak
My state ID
incorrectly here.
for a client?
Yeah, that's the benefit ID.
Yeah, then you should be able to enter them into the EVV system. But it won't affect anything in DXC's claim system. So you don't have the part there. Your EVV will still capture that you did it on a certain day with a certain client. So there won't be anything missing on the EVV end.
So as long as I have a state ID, I can put the client in regardless of whether or not, in the EVV system, regardless or not if I have put it into DXC or have a PAR or whatever, and I could start verifying and that record will be there from whenever I can submit the billing for it.
Yep, as long as you have that and you're billing Medicaid.
Okay.
And I'm assuming that that's.
And if I don't have a state ID, then I can input unknown client and put it in that way. Which,
Okay, we might have time for one more question. It's 11:58, so yes.
How long does it generally take once you input a person into the new system that you can then go out and complete services using the system?
My understanding is it's immediately.
And yeah, I mean, I don't know if it falls into the file transfer that goes in overnight, so I would say overnight at that 3 or 5 a.m. that we were talking about earlier.
But it's also important to know that the EVV system, the state solution EVV system, is one-way information. So the state isn't, once the information it is there, it's possible, the member has a full Medicaid ID, all the rest of this, that information is not automatically loaded into the EVV solution. All of the EVV information comes to the state as it comes through. And so the state solution is web-based, it's immediate, right? As soon as it goes across the data connection, et cetera, then it's uploaded into what's going on with Sandata, right? But then for it to come across into the MMIS and be a part of the system, that is the overnight thing to bill against, to match the bill against.
No, so as soon as you enter the client into your EVV solution, you can begin collecting EVV data immediately. Yeah. Okay, we're 11:59. Again, my name is Lana Eggers. I manage the Waiver Administration and Compliance Unit. We'll see Danielle Walker back here in a few months. If you have any questions, evv@state.co.us. Okay, thank you guys for your participation.
Thanks for sharing. I didn't realize you have to. Oh, I know.